Clearly, this is a vulnerable population, economically disadvantaged, coming from a racial and ethnic minority, often uninsured, especially after childhood, often low income. The only thing that's not checked on this typical list of what makes a vulnerable population, and this was not a sickle cell specific list when it was put together, it was a list meant to identify vulnerable populations. The only thing that's not checked is HIV. But everything else, these patients line up and they identify or can be identified as vulnerable population. How well have we done? You've already heard. We have improved childhood care, and the current death rate or age at death with sickle cell disease is higher than it used to be. But you've already been quizzed, and on the quiz, some of you thought that the age at death was continuing to go up, and in fact, it's going down. It's going the wrong direction because the adult healthcare system and the care for adults with sickle cell disease now responsible for 2/3 of the population, 2/3 of patients with sickle cell disease are adults. That healthcare system has these overlapping themes, and we don't really have a structure and we don't have a process to do good adult care. So, how do we approach it? Well, in order to approach the onion, in order to approach the various barriers, we need different kinds of science than what we've just typically been applying to take care of a disease. We do need the biological sciences, clearly. But as the book, Dying in the City of the Blues implied, we need to understand a little bit about political science, social science. I didn't go to medical school to learn this, folks. This was put upon us as we started taking care of sickle cell patients, and we had to step in and get our feet dirty, often our knees dirty, up into the muck, to understand how to apply some of these sciences. And now this new fancy term called implementation science. That is, how do you build systems of care to make the right thing done all of the time? And we need to apply all of these kinds of sciences to care for patients with sickle cell disease. So our traditional understanding then of the difficult patient, which might go something like this. The patient's difficult because they're angry, demanding, won't talk to me, and they're demanding opioids. And he might have a gun in his pocket. I don't know. Sort of look like George Floyd to me. That kind of attitude isn't going to cut it and isn't going to get us where we need to be with our patients. And the kinds of attitudes that you all outlined in some of the words in your cloud, those are the kinds of attitudes we need to understand and then teach. And we need to demonstrate and we need to propagate within the adult healthcare system. Talking about nuanced dimensions of sickle cell disease, now that you understand all the biology that we talked to you this morning, the complex biology, things like the morphine metabolism is faster, so maybe that's why they're asking for higher doses of opioids. Things like, they don't hold on to oxygen very well, so maybe that's why their O2 levels are as bad as they are, or perhaps they take only a little bit of their hydroxyurea because they can't tolerate it. We have to redefine what the difficult patient is. And so pick one of those words that you came up with in your word cloud and substitute it for difficult. And then we have to make these disciplines overlap in our application. So I just laid out here an example of trying to overlap the disciplines and apply the disciplines to care. And here I've given you some examples of what could be done, approaches that could be done in each of these disciplines. And here I've given you specific interventions, specific things that you could do that might be an application of those kinds of sciences. I'm not saying that I've done them all, but I am saying that those are the kinds of things that are programmed, and I hope when you leave here, if you have a sickle cell disease program or if you want to start one, I hope your program will try to apply these multiple sciences to the care of patients with sickle cell disease so that you can give very, very good holistic care. Now, why are we doing SCCAPE, folks? What is it that SCCAPE is trying to do? So let's break down the title. It's Sickle Cell Disease Care Coordination to Improve Patient Empowerment. Can you see now why we named SCCAPE the way we did? Clearly, our approach needs to be patient-empowered, patient-centered. Clearly, our approach needs to be coordinated, applying all of these sciences. Clearly, our approach needs to be sickle-specific. What you would do for a diabetic is different than what you would do for a patient with sickle cell disease. But then we have to get past the theoretical, and we have to come up with practical, individualized, feasible things that you can do, solutions that you can take away. That is what we hope we do for you during the SCCAPE conference. So when you walk away, you will have some practical, I'm going to try this when I get home, solutions for the, quote, difficult patients that you see. The foundation of our work really is scientific. We're starting with the literature, and we're starting with science, and we're developing interventions based on that science. And then we are applying those interventions and testing them to see if they work, much like you would in a quality improvement plan, and then check your actions, PDCA cycle. And then seeing from that what you need to do differently. What did you learn from that attempt? And tweaking it. That's where we are in the care, especially of adults with sickle cell disease, but I dare say in the care of all patients with sickle cell disease. So this PDCA cycle I've adapted here to say we have group science, we come up with multidisciplinary interventions, we test those interventions, we learn from those results, and then we go back and we tweak again. Let me give you an example of this general approach that we're using for SCCAPE and for our programs. And let's just talk about the one area that we've been hinting at all morning long, the most difficult perhaps area, the area of pain. Are you ready for a ride? Here you go. How about that for a model? So this model is one we just came up with. My colleague and co-author, Dr. Martha Kinney at the University of North Carolina, an anesthesiologist by training, developing pain expert. Together we started looking around to try to answer the questions you guys raised earlier today. Things like, is acute pain the most dominant part of the pain experience, or is chronic pain a part? And when there is chronic pain, how do you treat it? And are drugs the only way you should approach it, or should you be doing other things? And are patients who have different psychological burdens, do they come to their pain experience differently? And I think the answer to that is yes, and it's even more complex than that. So a guy by the name of Melzack came up with this basic diagram that you see here to try to explain all of pain, not just sickle cell pain, to try to explain the pain experience. And he proposed that there's a cognitive aspect. I know I'm having pain. I recognize I'm having pain. There's a sensory aspect. The signal is causing my nerves to buzz. The buzz goes up to my brain. And then there's an affective component. I feel some kind of way because I'm hurting. I don't like the fact that I'm hurting. I'm scared because I'm hurting. I'm not active because I'm hurting. I hate that I hurt. I'm depressed. It goes on. So there's affective, sensory, and cognitive aspects to pain. And then that gets expressed on the right-hand side in various ways. Obviously, in the middle, there's the pure biological brain sensory pain idea. And then today we told you that the brain sensory part of that is even more complex than what's on this diagram, and that at some point the brain may become automatic. But above there is a motor part of it. I do less, I do more. I maybe distract myself. I listen to tunes, I bop along. I do things to try and respond to my pain by either changing my physical environment to do more, or my physical activity to do more or to do less. And then at the bottom, the stressors that I feel get expressed in certain ways. I might react in certain ways that my family doesn't like, and God forbid my nurse who's got my opioids doesn't like. And I might get an attitude that everybody can see, expresses my stress. This diagram is very, very heavy. I'm not going to try to go into everything that it's trying to say, but I think you can see that this is an application of a general statement of trying to bring all of those kinds of sciences down to the level of treating patients with pain who have sickle cell disease. So, what are some of the applications end up being? Obviously opioids, but how about non-opioid drugs? How about the treatment of the depression and the anxiety? How about the cognitive behavioral therapy that someone asked about earlier? The mindfulness that we talked about, the acceptance and commitment therapy that we talked about. So non-drug pain treatments, TENS units and the like. What about educating the patient on distraction techniques? Maybe that guy listening to the unheard tune was distracting himself from his pain and not just ignoring everybody. What about provider education? And we did an NIH conference recently on pain and sickle cell disease, and I will tell you that the dominant call of all experts gathered from all walks of life in that conference, the dominant call was for provider education on cultural sensitivity and a better understanding of pain and sickle cell disease so that that poor 19-year-old can get a break when they come to the emergency department, so that they aren't doubted, so that they aren't under-medicated, so that they aren't put in a corner for 3 or 4 hours before being seen, so that they aren't told that they're a bad boy, so that they aren't dismissed early, so that they are given adequate follow-up opioids on discharge, so that they get an appointment with their sickle cell provider and somebody actually follows up to make sure that they make that appointment, so that they get a psychological evaluation and behavioral therapy to assist them with some of that attitude that's likely on their shoulder because they've been getting mistreated for 20 years before they came to that emergency department visit. So we've got a long way to go. I think you can see that we're sort of, if we were climbing Mount Everest and we were calling the tip of, getting the top of Mount Everest, we were calling that the nirvana for sickle cell. We're somewhere down around, I don't know, base camp 1. So a lot of education necessary, a lot more than what we are doing currently to treat pain, to treat sickle cell disease must be done. But it can be done. We can apply these sciences, the biological sciences, the political science, the social sciences, and the implementation science to break these barriers to sickle cell disease care.